I remember distinctly. I was a fellow of a Mass General, and I was doing a hand replant. It was a pretty challenging cases because you're taking a hand and you're trying to reattach it. Well, first thing you got to do is you got to get, the carpus attached to the radius. You got to put a plate on there, a spanning plate. Well, when you're doing it by yourself in the middle of the night and you're tired, and there's certainly the stress of the trauma situation and being there sort of by yourself at night. It's not always easy to hold a hand in the correct position, get the plate on there, and drill the screws. It sort of falls off. Maybe you like it on one on the AP and you don't like it on the lateral, and then you got to wheel in this C-arm while you're doing it. So I remember distinctly thinking, man, it would be really cool if I could leave the unstable extremity on the table and be able to take the X-ray to the target. And that's when the light bulb clicked. I said, well, what if we could untether this? And then we started, what if we could miniaturize it in your hand, and what if we could untether it? And then we realized some of the limitations that the FDA requires in terms of untethering it, and we were able to get around that with engineering. And that's really the ingenious part, is being able to satisfy the specifications of the FDA through our intellectual property, which is basically changing the shape of the conical beam, knowing where we're at in position and time so they're always centered, tracking this with this at all times. Those are really the genius part of the IP. But then also miniaturizing the X-ray tube to get us a lower radiation but a clearer image, and being able to get us a more accurate image every time, because a lot of times if you bump the table or you bump the C-arm, you get a blurred image. Sometimes the hand moves or shakes when you're trying to get the image. Here you've got absolute stability because you don't have to move the hand. We've got a quick flash of 50 milliseconds, which is about 1/10 the time of the competitor, so there's less chance for motion artifact or distortion. We've sort of taken all that into consideration. This was not created with one voice. This was created with many voices, many parts of feedback. And I think it's the first X-ray device that was really built by orthopedic surgeons, and not by engineers who have no business being in the OR or know what the problems of our competition, that is the mini C-arm or the large C-arm. It's very big, it's very bulky, and most surgeons just hate it, myself included. So this was built by many voices of orthopedic surgeons and hopefully this will provide them an easy way to get their X-rays. Yeah, this is the version we use in clinic, but what's genius about it is that, certainly we have a big practice. I could send someone down to get an X-ray, but I can also have them in clinic get a quick X-ray that's immediately uploadable on my phone or my iPad. I can get any image I want. Sometimes I'm looking for just a very specific image, and I can't really describe that to the radiation tech. I can do it myself. So for me, doing hand and wrist, getting very specific X-rays when I'm looking for a particular thing. Also being able to do live fluoro in clinic is huge too. I can see the carpus move together. I can see the hardware move. I can make sure the hardware's not proud or anything's in a joint, so I can get live imaging, fluoro imaging. But also, if I got a broken wrist, I can pop it back into place and get the X-ray right then and there before having them walk down the hall, wait in line, and get an X-ray. I think anybody who's seen the transition over the past 50 years knows that we have to miniaturize things, and speed is everything in the OR, and every minute in the OR is $70. So being quick, efficient, getting the X-rays you need, it's extremely important. And then anytime you can miniaturize things and make it cheaper, more affordable, have easier access to images, and you make it better for the surgeon, you ultimately make it better for everybody else. But what they were really impressed with was the ergonomics of it, the form factor of it. The fact that it's very portable, can be used in clinic, in the OR, has numerous markets that it's going to open up because it's portability. And that includes home health, military, correctional facilities. Certainly taking this abroad to many mission trips, it's just going to open up a whirlwind of indications. But ultimately, one thing that they were impressed with is the radiation. The radiation is far less. We've demonstrated that in our study, and people are pretty wowed by that. And me, over the course of my 30-year career, it's something that I think about. Being able to shield myself from radiation, not only myself, but my patients, my surgical staff. It's all gonna make things safer. So I think being faster, safer, and then ultimately using some of the software stuff that our engineers are working on to make a clearer image. CT joint, which is a small joint in the wrist. It's very hard to know which joint you're in, and in the foot and ankle, it's the same thing. A lot of foot and ankle doctors bring fluoro into the room. Well, it's a 400-pound ACR. This is a 5-pound emitter. So if I'm putting the needle in, you put the needle in, have my assistant take the X-ray, boom, save the image. I just got a fluoro guide injection. So for the clinic, I really like having quick access to images, getting very unique images that I require in the particular surgeries I do, having the ability to use live fluoro to look at the motion of the wrist, and also demonstrate that to the patient. And lastly, just using it for fluoro guide injections. I mean, that's helpful. It's paramount to know where the needle is. Sometimes you're guessing, and this will confirm your placement.
Did you guys want to play with it? Want to see it?
I'll break it if I touch it.
Oh, it'll be fine. So, but I think ultimately,
Here so far.
I think when people saw this, most surgeons are like, "Wow, that's." A lot of people are like, "Well, I sort of thought of that." Like, well, okay, but it's here.
But you didn't do it.
Right. There's one guy that came by this morning. He's like, "I thought of this idea 15 years ago." I go, "Well, this is it."
Yeah.
So, I mean, I think ultimately surgeons hate C-arm. I really think they do. And they complain about it all the time. I know I complain about it. And it's probably been a technology that's been overrun by MRI and CT and PET. And the GEs, the Philips, they put all their money into PET and MRI because they made a ton of money, and they just sort of left fluoro in the back burner. But I want to bring it back to the front burner, so to speak, because I think we can really do some cool stuff.